Good afternoon, ladies and gentlemen. The subject of my presentation is validation of Acute HIV-1-2 detect for detection of acute HIV infection at Anonymous Clinic, the Thai Red Cross AIDS Research Center. Diagnosis of acute HIV infection is important for prevention and care. Nucleic acid amplification test or NAT is the most sensitive test to diagnosis acute HIV infection but is costly and labor-intensive. Acute is a point of care qualitative NAT that can detect both HIV type 1 and type 2 with a detection limit of 2,500 copies per ml. Aim of the study is to evaluate the performance of Acute in Thai acute HIV infection detection. Acute was run against a panel of 100 plasma samples. Group A confirmed HIV negative 10 samples. Group B, fourth generation enzyme immunoassay non-reactive but NAT or Optima reactive 30 samples. Group C, fourth generation reactive but third generation non-reactive 30 samples. Group D, fourth generation and third generation reactive but second generation non-reactive 30 samples. The table shows Acute HIV RNA detectable stratified by group. Group A, Acute cannot detectable. Group B, Acute can detect 21 samples or 70%. This group median quantitative HIV RNA is 4,337 copies per ml or log 3.64. Group C, Acute can detect 30 samples or 100%. This group median quantitative HIV RNA is 3,694,414 copies per ml, log 6.57. Group D, Acute can detect 29 samples or 96.7%. This group median quantitative HIV RNA is 2,824,395 copies per ml or log 6.45. 8 in 9 Acute negative samples had HIV RNA below the detection limit of Acute 2,500 copies per ml and the remaining one had HIV RNA 40,311 copies per ml. This sample was repeat both of HIV RNA and Acute with the same result. Median HIV RNA of acute HIV infection with reactive Acute was 630,276 copies per ml, which was significantly higher than those with non-reactive Acute that was 282 copies per ml. P-value was less than 0.001. Acute is more sensitive than fourth-generation machine-based enzyme immunoassay but less sensitive than Optima. Acute is ideal for HIV testing in paper-taking prep, especially at community rollout. In addition to its indication for use in mother-to-child transmission, Acute could be considered in the detection of acute HIV infection in the setting where Optima or HIV RNA is not available, although its sensitivity is not yet perfect. Finally, thanks for our staff at Anonymous Clinic, the Thai Red Cross AIDS Research Center, and thank you for your attention.
Thank you very much. We'll hold questions and discussions until the end. So it's a pleasure to introduce Jintanod Anand-Warnich, who's going to tell us about a favorable clinical profile reached in less than half of people treated during acute HIV infection.
Thank you very much for the opportunity to present here on behalf of our study teams. And I'd like to acknowledge the participants in our studies that have contributed significantly and the investigators and the sponsors. And these are my disclosures. So we now have the opportunity to look at clinical outcomes in the acutely treated participants in Bangkok, Thailand at the Thai Red Cross AIDS Research Center. And we started the study in 2009 and so have now several hundred people that have been on treatment for several years. And so we wanted to look at a favorable clinical phenotype, and we defined it as having no serious adverse events, having high latest CD4, high latest CD4-CD8 ratio. And CD4-CD8 ratio is a marker of, if you have low CD4-CD8 ratio, it's a marker of immune dysfunction. So this just says, how well is the immune recovery. And we also looked at viral load suppression less than 20 copies without any blips after week 24. And this could indicate perhaps the size of the reservoir or very well-controlled HIV. And so we also compared our data in 246 acutely treated participants with chronically treated participants at the same center who were age and sex match. And you can see that in at least using these definitions, about 40% of acutely treated people who've been treated for about 3.5 years versus chronically treated people who've been on treatment for longer, close to 5.5 years, that the acutely treated people did better. And if we look at people who were treated at different stages of acute infection, FEBIC1 being seronegative 2 weeks after onset of infection, FEBIC5 being Western blot positive, but P31 band negative, and about 6 weeks following onset of infection at time of ART initiation. So we see that there's a trend for better outcome in FEBIC1 treated versus FEBIC5 treated participants. So we wanted to see now what component actually drives these differences. And so if you look here at serious clinical adverse events, we see that no matter if people were treated in acute infection or chronic infection, and these are mostly people who did not have AIDS-defining illnesses, that they do well after ART. On the right is the CD4 more than 500, and people also do well, and we did not see a significant difference between people treated in acute versus in chronic, and no differences between people treated at different FEBIC stages. And so what really differ between the groups are the latest CD4-CD8 ratio more than 1. We see more people treated early achieving this compared to people who are treated later. And in terms of the different FEBIC stages, we see that the FEBIC1 did slightly better. I mean, this is far from being significant statistically. But and also the no viral load blips, we also see the acutes doing better than people treated later. And a trend for people treating very, very early in FEBIC1 doing better than people who are treated later in acute infection. So in summary, we see that when people are treated early, they have higher rates of favorable clinical phenotype, at least as defined by the study. And even when we treat so early during seronegative acute infection in FEBIC1-2, we don't see complete immune recovery. And so this, I think, provides an opportunity to study this further. Why do some people have favorable clinical phenotype? Why some don't? And really, this could perhaps help us in devising ways that could improve the current antiretroviral therapy. So I'll stop there. Thank you very much.
So the next speaker is Ricardo Sobi Diaz, who will talk on a trial with arafenib and nicotinamide in HIV reservoir.
Okay, first of all, I'd like to thank all the patients that gradually were involved in this study, donating samples and more. So this is a clinical trial. We have first to acknowledge that the barriers for HIV elimination is the residual HIV replication. This is being debatable lately. The viral cell latents and the viral sanctuaries. So this is a pilot proof of concept, open label, randomized clinical trial. This is the number of the clinicaltrials.gov. And we enrolled 30 patients that were allocated in 6 distinct groups. Those patients were with a CD4 nadir over 350 and viral load below detection with antiretroviral treatment for over 2 years. So we get samples such as blood, saliva, urine, and a biopsy, rectum biopsy at the baseline and at the end of the study. The control group is the patients that were kept in the original antiretroviral treatment. The second group, we have a antiretroviral intensification with dolutegravir and maraviroc. As far as I know, this is the first study that used 2 drugs to intensify the treatment. Dolutegravir because of its potency, and maraviroc because they have some anti-latence properties and also inhibiting apoptosis. We also use it at the third arm, the intensification with the 3 drugs and nicotinamide. We were very lucky to find that nicotinamide had some very potent anti-latence activity. When we compare this with 2 histone methyltransferase inhibitors, it was faster and more potent in vitro. The fourth arm, we have the intensification plus oranophine, that's the gold salt. We know that the gold salt is going to drive those cells to apoptosis. They have anti-proliferative capacity, and we have some in vivo data in monkeys from Andrea Savarino showing that this can decrease the viral reservoir. The other arm, we use only intensification with dolutegravir because we are going to do the dendritic cell vaccine after 48 weeks. These are 3 doses of dendritic cell vaccines every 2 weeks. We build this based on GAG peptides and the HLA profile of every patient, so they are autologous antigens. And we chose between 2 and 6 peptides for each DC vaccine based on the affinity of those to the DCs. And the last arm, we have everything. We have the intensification with dolutegravir. We also have the HDAC inhibitor nicotinamide. And we have for 6 months the gold salt. And after that, we have the dendritic cell vaccine. Those are the main results. So when you look at the effect of the intensification plus nicotinamide and oranophine, the gold salt, we see that the proviral DNA in PBMCs have a very steep decay, which is not found in all other groups. The other important feature is that we have checked for inflammation, for cell activation at baseline and at week 20, which is the maximum effect of oranophine. And we shows here the group 1, that was the patients that get the same treatment. Group 2 that have the intensification only with dolutegravir and maraviroc, because we have that effect of maraviroc in decreasing cell activation. And what we can see, it's that only in group 6 that we have everything, nicotinamide, gold salt, and intensification, we have a decrease of cell activation markers. The sample size is very low, but it was significant for the CD38 in CD8 and in CD4 for the group 6 that we have everything. Those are the results from the vaccine, the in vitro immunogenicity results from the vaccine. So we got the cells from those patients, and we look for intracellular cytokines upon stimulation with the peptides, or in a control group, we stimulate with endotoxin of Staph aureus and other antigen. And what we can see is that in CD4 and in CD8, we have an increase in immunogenicity when we use that vaccine. So the baseline is the first dose of vaccines, how the patients are. The second dose reflects the first application of the vaccine, and the third dose reflects the second dose of vaccine. So we have that increase that's statistically significant for CD4 in all three cytokines here. Then it goes back 2 months after the vaccination, showing that this is a booster and not a definitive increase in the immunity. And this is these are the two groups that got the vaccine. And it's interesting that the group 6 that they have everything. There is one patient that had the PBMCs, the DNA quantitative PBMCs below detection upon the introduction of nicotinamide and aranophen, and after the vaccination also. And there was one patient that was decreasing the DNA, and after the vaccination, we have levels below detection of the PBMC DNAs. 2 patients interrupt treatment by their own choice right after 48 weeks, and they had an increase in the DNA and also in the antibodies. So just to conclude here, we have more results. Interventions were safe with no major grade 3 or 4 adverse events. That was kind of surprising to us. There was a transient decrease in CD4 counts at week 8 and 12 in those 2 aranophen groups, which is good because it shows us the lymphoproliferative inhibition of in those 2 groups. There was a decrease in antibody quantitation over time in groups 1 to 5. Group 6 have very low baseline antibodies. And this was not seen as statistically significant. And none of the patients negativate proviral HIV DNA at rectal biopsy. There was a correlation between the HIV proviral DNA quantitation at PBMCs and rectal tissues at baseline, but not at the end of the study. So in conclusion, aranophen and nicotinamide significantly decreased viral load in intensified ART-treated individuals, with 1 individual involving with undetectable levels of HIV proviral DNA in PBMCs. There was a decrease in the marked inflammation levels in the aranophen and nicotinamide group and ART intensification, that's group 6, as suggested by the activation marks that decrease in CD4 and CD8. The CD38 marker. After autologous dendritic cell vaccination, 1 individual from group 6 also evolved to undetectable levels of HIV proviral DNA in PBMCs. And our aranophen and nicotinamide administration in combination with intensified ART was well tolerated and safe. And now we are planning an analytical treatment interruption for some of those patients or all of them. Thank you for
Okay, thank you very much to all the speakers for concise but in fact impactful presentations. We now have some time for questions and discussions.
Hello. I'd like a question to Dr. Anna. Your group of FIBIC1, the best, about half. Is it all patients or just patients that remain in the follow-up until the end?
Well, I mean, everyone is in follow-up. But they've had different, very few, like 10 out of 530-something participants, yeah. And the viral suppression rate is quite high. It's over 95%.
Okay, hi. Thank you. Casper Rox from the Rossum Medical Center. I have a question for Dr. Zoe Diaz. Also, congratulations to all speakers. It's a very intense trial with 6 arms that you presented. And I was wondering what would be the explanation for the differences you observe in the Maraviroc arms, group 3 and 4, if I remember correctly, and the all-out group 6, where you do everything. If I remember correctly, in your graph on HIV DNA, it shows a tendency to increase in the Maraviroc arms, while those are also dual shock strategies with one of the other compounds you use, while in the group 6, where you leave out Maraviroc, you can see a tendency to decrease. So I was wondering if you could comment on that, what could have caused the difference, or if this could have been merely by chance.
Yeah. Should I turn this on? Is that okay? Yeah, okay. So there is one piece of data that I didn't show to you when we used 2 drugs, Maraviroc and dolutegravir, and only dolutegravir. There was a decrease in the DNA in the 2 drug used. Yes, there are some results that were not intuitive to us, such as the vocation of Maravrock to decrease the proviral DNA that was seen in other studies, and also to decrease the activation markers. So it looks like that the combination of dolutegravir and Maravrock is not as bad as it looks there, even if you look at the other groups. But what really makes the difference, in our point of view, is the association of all those strategies. As far as I know, they are using sometimes a latency inhibitor with a vaccine, but we use four types of interventions. That's HDAC inhibitor, the ranolfin, intensification, and plus the vaccine. And that was what I think that makes that result more intense.
So do you think that the addition of putting a vaccine in group 3 and 4 would have altered the results there as well?
Yeah, I do. I do think so, because the idea of the vaccine, it's just to teach the CD8s to get rid of those cells in sanctuaries or those cells that even are latent, and we know that some latent cells can signalize that they are infected. And as we see in vitro a very intense effect of the vaccine after the vaccination, we do think that this is going to make the difference.
And one last question, if I may. Do you plan to go ahead and do that in those groups?
Yes, the idea is to have, we are discussing if we are going to interrupt the treatment for many patients, or if we are going to do a rollover and bring all those patients that were in the less successful group to the group that had everything, and repeat all those procedures to prove that we can do it, and every patient is going to be a control of himself, because it's being in two distinct interventions.
All right, thank you. And again, congratulations with the trial.
In the meantime, before maybe other questions get up, I have a question for Erin. So you very nicely showed the testing of a new RNA point-of-care method. And in your final slide, you mentioned that one place of point-of-care RNA testing could be in the screening of participants for PrEP or individuals that want to use PrEP. Do you think that using an RNA test would be preferred over, let's say, an antigen-antibody test for screening these persons?
This machine is a screening test, and I think it's we should setting where optimal or HIV RNA is unavailable. It's okay for screening.
Yeah.
Community rate rollout.
Okay, thank you.
Can I ask the speaker?
Please do.
I'd like to ask the last speaker. I'm quite impressed by your results, because even when giving 4 different therapies, if you look at the total copy of total HIV DNA, it seemed to decrease from 30 to 10 copies per 1 million cells. And it just seems so daunting, because with 4 things you can decrease by 20 copies per 1 million cells. And so it maybe just shows us how much we have to do to try to get to below detection, which you can do in a couple of patients. But in terms of treatment interruption, my feeling is that it just takes 1 cell to reactivate. And if you have 10, you end up with 10 copies per 1 million. Whether, what is your thinking? I guess you're looking at time to viral load rebound as your endpoint, or are you looking at how many people end up controlling?
The idea is, first of all, we decided to do that vaccine with peptides because we have been able to get the virus in a very high quantity of the cells. The idea to use the whole virus. And what we have is that we have a little blip of the virus in everybody, then it just waned. It disappeared, the virus in the culture. And when you look at this, we published this, all the viruses were defective in the electron microscopy. They were very small size, without double membrane, and sometimes without the capsid. And we have done NGS of those cultures, and we see that it's very uneven, the cover of the virus there. So they are, most of those viruses are defectives. So even if you can decrease the pool size of the DNA, we think that we are changing the ratio of competent and defective virus. And we may have only defective virus and get a cure in those patients. And also, when we plan to boost the immunity, it's just because of this. So when we start to emerge something, we hope that this new cellular immunity can contain those viruses. So, but of course, we cannot say anything without interruption.
Let me follow up a bit on that. So in terms of the intact proviruses, these new assays for looking at intact versus defective proviruses in the Visconti cohort and also in the FEBIG participants, are there plans to bring in some of these new assays, and what might you expect that those would add to the analysis?
Yeah, we have many assays that are pending. One is this: we have to do cell-associated RNA, cell-associated DNA as well. We think that we need to do metabolomics to show that the profile of the patients are getting closer to uninfected patients. So we are planning to do that, even to try to sequence the virus to see over time what's the difference. And this might give some insight to us towards the size of the defective virus. But we do, yeah.
And for the Visconti patients, we have sequenced transcriptase inverse gene. We observe for certain patients hypermutation or stop codons, but it's not different than control groups who were patients treated at the time of the primary infection or in the chronic stage with similar time of treatment, or natural controllers. And other analyses are ongoing.
Staying to the Visconti cohort, I was wondering, so you nicely showed that in the three different groups, so the complete controllers versus the progressing patients, there's a difference in the inflammatory profile. Maybe I forgot it from your presentation, but did you also look at longitudinal samples? In other words, is it merely a reflection of viral load replication, or is it something intrinsic to the real controllers?
In fact, just to be more accurate, we measured levels of inflammation markers in only patients with no intermittent viremia. We have not enough patients with intermittent viremia to look at them. And it's just one point. It's at the time they enter into the study. It's not longitudinal assays.
Please go ahead.
Thank you. I have a question on the Visconti patients. Which published assay on which published allo-PCR assay did you use to measure the integrated DNA?
Data of quantification of integrated HIV DNA in Visconti are ongoing, and we developed an allo-PCR, an ultra-sensitive assay by allo-PCR.
But is it a derivative of the original method of Una Doherty, of the method of Tan, the method of Van der Goite?
We adapted the method of Brussels.
Okay, or the Brussels.
Okay, maybe I could invite Jintanad to speculate if you'd like. I'm just curious your thoughts, if you want to share, on what might distinguish the people with these favorable outcomes versus not?
Well, speculate, okay. I do think that there's some perhaps persistent infection in tissue that in some people might still be the case, and perhaps that drives immune activation. I mean, at least in the gut, in the lymph node tissue that we have looked at in the cohort, there's definitely fibrosis that's not resolved in some people after treatment. So what is driving tissue fibrosis? We see persistent RNA-positive cells, DNA-positive cells in tissue. So those are some of the things that we'd like to look into more. And I see Liddy here. Maybe she wants to speculate too. No? Okay.
Any other questions? Any questions from the panelists for each other?
Well, I can do one. So I'm just curious about the Visconti cohort. Aside from seeing viral load blips, are there any other markers you can see earlier that would say who will eventually have persistent
We have
control?
not enough patients to plan many statistical
How about
analyses.
single copy RNA?
Using the single copy,
yeah,
if
when they're
split
suppressed.
the patients into different groups? I don't really understand.
No, I mean, if you look at people when they were still suppressed and you do single copy RNA, do they already have a little bit higher, the ones that eventually will lose control?
For inflammation
like
marker?
low-level viremia?
We have not enough data to respond to that.
Jim Braun from PRN in New York City. Two questions, one to Erin Srila-Orr, and then second question to the whole panel. The determined test does seem to function well as a rapid test detecting antigen in plasma, but it doesn't seem to perform so well for whole blood. And since it was designed as a point-of-care rapid test, if it doesn't, I'm just wondering whether you are doing any kind of comparative study to see whether you can use whole blood from finger sticks in point-of-care service and whether this will compare to plasma results. Because it hasn't worked out very well in the US to my knowledge. And also then for the whole panel, are any of you working with newer technology to detect HIV rapidly at point of care that can diagnose acute HIV during FEBIG stage 1 or 2? Because that's really what we need if we want to get people on treatment early enough to bring about some lasting outcome results.
I'm not compare whole blood and plasma, but my sample is storage plasma for 5 years. This is a select acute HIV infection in my laboratory. Storage plasma.
We are not looking at point of care testing yet in our cohort.
We don't have access to this technology yet.
Or any kind of rapid testing, so that you don't lose time while you're waiting for the results to come back.
I mean, the way we do HIV testing screening is that clients walk into the anonymous testing center and then they get 4th generation immunoassay, and that's free for all Thai nationals. And then the ones who are negative to that, we do pool nucleic acid testing. I mean, that's by not point of care and not rapid, but I mean, we do it every single day. So, in one day we know who is have acute infection, but that's really very research oriented. I don't know, we use the Aptima test, which is a qualitative test, and when you pool, for instance, you have 30, 40 people, you can pool all 30 and do just one Aptima test. And if the pool is positive, then you start breaking down pools, and you can do a pool of 10 and do 4 pools of 10 to cut down the cost. But that is definitely labor intensive.
Maybe I can briefly comment on your question for the, it goes to the Acute study that has been done in Thailand, and thanks for the great data that has been presented. So of course we have internal data that the Acute detect platform works very well with whole blood. So it has been validated for the use with whole blood. So we show equivalence between plasma samples and whole blood, if that answers your question.
And maybe I can add to Jintanat, although I'm not presenting formally in this session, but in Amsterdam we do use point-of-care RNA testing for diagnosis of acute, but I think it very much depends on the setting you're working in, since it's quite expensive, and basically we test people based on symptoms, and then they are offered immediately an RNA test in combination with an antigen antibody test. But realizing that it's quite expensive to be able to diagnose only very few people with a very early acute infection that you would have otherwise missed.
I have a question too. Is there any difference between CRF1 and B in the size of the number of acute infections that may give you a clue if the epidemic is growing for one subtype or another?
Well, CRF01AE is very dominant in Thailand, so about 80% or more are CRF01AE, and then the rest are B or recombination. So I think it's been pretty stable over time.
Yeah, Enrique Prins from the Erasmus Medical Center. I have a question for, I think, the entire panel. I wondered if you consider doing CCR5 genotyping, because it's been shown that some people who are heterozygous for a certain deletion, they have a far slower progression of their HIV infection, and I guess that deletion could really confound your findings in both vaccine trials as well as acute HIV-infected patients.
I'm trying to remember the data, but I know that homozygous CCR5 doesn't exist in the Thai population. I mean, studies have been done that there's no. So I would say it's extremely rare, I think.
Because I think,
but I can't remember the exact data.
I think in Caucasians, 20% is heterozygous. So
right. No, I think it's rare in the Thai population.
In our study, we have done this, and they are all homozygous CCR5 white type.
Yachi Ho from Yale. Adding one point about point-of-care detection of acute viremia. Like Jennifer Dunn at UC Berkeley recently published about Cas13, which can be used as a point-of-care rapid detection of RNA or DNA. Has never been tested in HIV, and whether sensitivity is specific, no one knows, but in case anybody in the audience would like to try, that could be one direction.
Any other questions? If not, we can end a bit early, but maybe going once, going twice. Okay, thank you everyone for a great session.